Thank you very much, especially Professor Taneja and his team for inviting me to talk here. And it's really a privilege and honor to be here. My talk is on electrodiagnostic testing for orthopedic surgeon, and I'll keep it very brief and very relevant to 80% of the orthopedic surgeon. The first thing is, if you get a closed fracture and neurological deficit, how do you use electrodiagnostic test to reach to a conclusion where to explore this nerve or to continue to treat it non-operatively? Second situation comes, suppose you got a peripheral nerve entrapment like carpal tunnel, and then do you really need electrophysiological study? Of course, if life is this simple, that you know the diagnosis and clear-cut symptoms, then probably there's no role of electrodiagnostic testing. But unfortunately, life is not that simple. It can be vague aches and pains and pins and needles, so it can have a confusing differential diagnosis, or you may need electrophysiological study to have an objective baseline for future reference, for litigation, or for insurance purpose. So what are the electrodiagnostic studies? I'll keep it simple, not go into very detailed specific test. I'll just mention about nerve conduction study and EMG. Before we do that, I want you to know a little bit about anatomy, physiology, and ionic exchange of the nerve to understand the electrodiagnostic studies. So anatomy, as far as concerned, nerve is an axon covered with 3 layers of connective tissue. Immediately outside the axon is endoneuron. Then these axon with endoneuron are clubbed together into fascicle, and they're covered with second connective tissue called perineuron, and the perineuron with the vascular again covered with another connective tissue called epineuron. Little bit about the neuron. Dendrites are responsible for incoming information, cell body for integrating them, axon for transmitting them, and a terminal releasing the neurotransmitter either to neuromuscular junction or to the next nerve. How is the signal transmitted in a neuron? If you get any stimulus, chemical, mechanical, it actually first generates a graded potential. The graded potential can add it or subtract it, but next potential, if once it is triggered, action potential is actually all or none rule. So physiologically, inside the nerve, you have negative, which is called a resting potential, which is actually maintained by sodium chloride being outside and potassium and the protein anion being inside. And this sodium-potassium imbalance is maintained by a quite important mechanism, ATPase pump, which is energy efficient pump, and this maintains this disbalance, and hence the negative side inside the nerve and positive outside. So when the stimulus comes from minus 70 resting potential, you get a graded potential up to minus 55, and as soon as you hit minus 55, you get the nerve action potential, which reaches peak, and then from peak it starts getting repolarization, and after repolarization, quite often it overshoot and become hyperpolarization. And this is important thing because what happened is initially the sodium channel open, and then little later the potassium channel open. And once this repolarization and hyperpolarization is happening, the nerve is actually in a refractory period. And this concept is important to understand because once it is in a refractory period, the further depolarization will not happen in that node. It will only happen in the next node. And that's why physiologically the nerve transmission is orthodromic, not antidromic. At the end of the nerve, the graded potential comes again, the calcium channel open, and the neurotransmitter vesicles are released, and the muscle contracts. So let's come back to the nerve injuries. Before we do electrophysiological studies, let's know a little bit about the types of nerve injuries. Sudden in 1943 classified them into neuropraxia, axonotomesis, and neurotomesis. According to him, neuropraxia is just a conduction block. Axonomesis is where the axon is disrupted, but the connective tissue is maintained. And neurotomesis is where actually there is no continuity between the proximal and distal end of the nerve. So you can immediately see there's a fallacy with this classification because axonotomesis can have few categories where connective tissue can be disrupted, and hence the next classification, Sunderland, where the axonotomesis was divided further depending on whether it's just isolated axonal injury or axonal plus endoneuron or plus perineurum, and hence the 5 classification of Sunderland, which you are quite aware of. The second concept to understand is that once you get a conduction block, there is no Wallerian degeneration distally, but any injury which is a bit severe than neuropyrexia, there will be always Wallerian degeneration. And this goes all the way to the end of the nerve, whether it's a synapse or whether a neuromuscular junction. The Wallerian degeneration has to happen only unless it is just neuropyrexia. And so this Wallerian degeneration doesn't happen on the same day. It starts 2 or 3 days later, and then gradually depending on where the muscle is. And this is the important concept to understand for electrodiagnostic study, because the changes in that muscle will only happen if there is a Wallerian degeneration has reached that muscle. And once Wallerian degeneration has reached that muscle, if some of the connective tissue is maintained, then this growth of the nerve happen, and then regeneration reaches the muscle. And again, this is a time-consuming process, and this will take few more weeks. And hence that key question which you want to ask clinically, when is the right time to do electrodiagnostic study? Well, the right time is when the Wallerian degeneration has reached and regeneration has reached that muscle, and I'll come to that in the end of my slide, that in terms of weeks, what is the right time. So if a muscle has got Wallerian degeneration, it will show some electric changes, and it will show different electric changes if the regeneration is happening. So let's talk about the EMG changes. What you do in EMG is you put an electrode into the muscle and then see the activity at insertion, then wait for any spontaneous activity, and then gradually start contracting that muscle and see what that contraction potential look like. In normal circumstances, you will see a little bit of blip by irritation of the muscle when you put the needle in, then you see the spontaneous activity, and then you see this classic triphasic activity, the wave going down, up, down. And that's a classical motor unit potential. And then more and more motor unit potential are utilized, and then you become that interference pattern. So that's a classical, you stimulate a nerve, you get this triphasic wave if the nerve is intact. But what happens if you got Wallerian degeneration? As soon as the Wallerian degeneration reaches the muscle, you get 2 changes, fibrillation potential and positive sharp wave. So from this talk, if you just understand positive sharp wave and fibrillation potential are bad thing. That means the injury is more than neuropyrexia. As I told you, that's the only condition where Wallerian degeneration will happen. Once the nerves start regenerating, you start getting these polyphasic wave, which is a good thing. So polyphasic wave is good thing. Eventually it will mature into classical triphasic wave. So if you do EMG studies and the muscle starts showing fibrillation potential or positive sharp wave, that means Wallerian degeneration has happened. But if few weeks later it starts showing polyphasic wave, that means regeneration is happening, and that means this injury is axonotmesis, not neurotomesis, because it's regenerating. And if it is a lot of regeneration happening, you can wait. Although clinically there not maybe muscle contraction, but you can still wait for this nerve to regenerate and treat it non-operatively. And that's the same slide showing how it is to be done. Little bit about nerve conduction study. There are 2 types, motor and snap, which is sensory nerve action potential. You stimulate a nerve and see what potential it generates later on. And I'll try to be quick because we're running out of time. So when you stimulate a nerve, there is an action potential. The time difference is called latency. In a motor nerve action potential, actually it has to go through a neurotransmitter, a neuromuscular junction. So you stimulate at 2 points so that you can negate the neuromuscular transmission and you can get a true velocity of the nerve. So you stimulate proximally, you stimulate distally, and if you know distance between 2 latency, and if you know distance, a time taken between the 2 latency, you can easily calculate the velocity. And that's how the motor is done. For sensory, you don't need 2 stimulation because it's nerve to nerve. There is no neuromuscular junction, and you can calculate it. Little bit about the sensory nerve, because the cell body is in the dorsal root ganglion. So if it is a pregangliotic injury, you can find out that the nerve is actually transmitting electrically, although the limb may be completely anesthetized. And that way, you can differentiate between a pregangliotic versus postgangliotic injury. And this is important when you're talking about radiculopathies, which you can differentiate from pre and postgangliotic injury. In motor nerves, we also see sometime late responses, which are F and H waves, and they are important to know whether there's anything proximally happening. Sometimes the physiological changes, variation like Martin-Guber anastomosis, where some of the ulnar nerve initially may go through the median nerve, and then in the forearm, they cross over and go finally to ulnar nerve. With clever electrodiagnostic study, proximally and distally, we can find that there's a Martin-Guber anastomosis. And this can be done, again, with EMG and nerve conduction study together. So to summarize, EMG and nerve conduction study are just extension of physical examination. It can quantitate nerve or muscle injury. It can provide useful data regarding site, type, severity, and duration and prognosis of an injury. In a closed fracture, you have to wait for Valerian degeneration and the polyphasic regeneration wave to happen. So there's no point doing the nerve conduction study before 6 weeks. Wait for 6 weeks. But at the same time, there is no point waiting beyond 3 months, because by that time you will have enough evidence that the regeneration is happening or not. And after 3 months, if it is clinically and electrically not happening, then explore this nerve. As far as the nerve conduction study for carpal tunnel is concerned, this is mainly if you're not sure about the diagnosis, if you want to see if any other nerve is involved, or if you want to see, put it as a baseline for future reference or for insurance or for litigation purpose. In clinical clear-cut carpal tunnel, you really don't need it. So in the end, we are lucky that Valerian degeneration, which is a classical feature of nerve injury, is not a feature of bone. Imagine if you got a subtrochanteric fracture and whole of the distal end get Valerian degeneration and you are left with no bone. Thank you very much.